My name is Dr. Colette Smart, and I want to welcome you to my presentation, Nurturing Lived Experience, a trauma-informed approach to patient-partner collaborations in research. To begin, I would like to acknowledge and respect the Lekwungen peoples in whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanic peoples whose historical relationships with the land continue to this day. Before we begin, I just want to say a few more words to introduce myself. So, as I mentioned, I am a professor of psychology at the University of Victoria in British Columbia. As of 2024, I'm also the research scholar in residence for mental health and substance use at Island Health on Vancouver Island. That's the health authority for Vancouver Island here in British Columbia. Apart from my work in teaching and research, for many years I've also had a private practice in clinical neuropsychology, and my focus has been working with people with chronic or neurological illnesses and also trauma recovery, and many times those things go together. This presentation is being done in collaboration with the BC Support Unit, and I do want to take a moment to thank them and all the various members that I've had the pleasure to collaborate with over the last many years. And I want to particularly thank Hiro Ito, who was directly involved in the production of this video. So let's begin with an overview of my presentation today. I'm going to say a bit more introduction about how I came to put together this presentation and talk about what is patient-oriented research. We're also going to talk about what's trauma-informed practice and why do these two things go together. Then, for those of you who are researchers watching this, I want to talk about some considerations for supportive engagement for patient partners using a trauma-informed lens, and then we'll end with some conclusions. So I'd like to give a bit more introduction specifically about the patient-oriented research that I've been involved in. And broadly speaking, my areas of expertise are on complex trauma, medical trauma, and trauma-informed practice in healthcare. And I've been doing this patient-oriented work for about 6 years now and collaborated with at least 16 patient partners across 5 completed studies. And so the first of these, which I'm going to speak about more in this talk, is a project where we develop trauma-informed practice guidelines for neurorehabilitation. And neurorehab refers to the therapies and services that are often received by people who have suffered acquired brain injuries. The second project was looking at the experience of anoxic brain injury following non-fatal opioid overdose. The third set of projects related to CPTSD involve looking at cognitive function or thinking abilities in complex trauma survivors, as well as the development of an expressive arts intervention to support trauma recovery. And the fourth project is unique because it was actually initiated by a patient partner themselves, somebody who is a survivor of complex trauma. And they brought forward the idea to develop a healthcare toolkit that would educate healthcare professionals about how to provide trauma-informed care to people who had suffered complex relational trauma. And I just want to acknowledge the funders of our work and some of my many collaborators over these projects. So let's talk about what is patient-oriented research, and specifically the strategy for patient-oriented research. This is a approach that has been put forward by the Canadian Institutes of Health Research, who is one of the main federal funders of health research here in Canada. Patient-oriented research might exist in other countries under another name, but at least here in Canada, this is a term that we tend to use when we're talking about engaging people with lived experience in healthcare research. And really, the impetus for SPORE is to make sure that we are conducting healthcare research that actually has relevance to the lives of people who are seeking healthcare and also the people who provide healthcare. And so it's really about partnerships between academia and researchers and people who are intimately involved with the healthcare system. And there's a sense that we want to transform patients and their families from just passive recipients of health services into proactive partners who help shape health research and healthcare. And partnering with community organizations and healthcare providers is also an important part of this because they can help us make sure that the recommendations we provide are actually meaningful within the healthcare system. So, from a practical standpoint, for patients, it means getting to have a say in which health topics are researched. For researchers, it means benefiting from the perspectives and experiences of patients. And for the healthcare system, it means having access to the research evidence that decision makers and healthcare providers need to actually improve care for patients and families. And I think this is captured well by this mantra from the disability advocacy community from many years ago: nothing about us without us. So it's really a call to action for those of us who do healthcare research to make sure that we are actually including people directly affected by these health conditions to be part of the conversation. And it's about doing research that is ecologically valid, meaning that it actually makes sense on the ground in the real world and is actually going to be clinically applicable. So now let's switch gears and talk a bit more about trauma informed practice. So, this has been a movement in healthcare that has been ongoing for some time, and it's slowly making its way into various sectors of healthcare. So, rather than singling out people who have trauma for special care, it's really an organizational or systems level practice or set of practices where it's assumed that a significant amount of people coming through healthcare will be dealing with some kind of trauma in their history, and we can establish systems of care that are welcoming to everyone, regardless of their exposure to trauma. There's different ways that TIP, trauma informed practice, tends to get articulated, but there does seem to be some general consensus on these four key pillars of TIP. So, the first pillar of TIP is trauma awareness. And so, this means knowing what trauma looks like, who it affects, and how it can show up in a healthcare environment. The second pillar is safety and trustworthiness. So, that means being transparent, open, and reliable as providers, making sure that we engage in continuous informed consent and establishing a felt sense of safety with our patients or with our research participants. And this is very important for trauma survivors who end up navigating the world from a place of fear and survival. And so safety is absolutely crucial. The third pillar of TIP is choice, collaboration, and connection. And this is really about restoring autonomy, fostering dignity and self determination, and working together as a team. So, I often think of trauma as a condition where people have had their autonomy, agency, and control taken away from them. Usually, by definition, trauma means that something has happened to you against your control, your choice, or your consent. And so, being able to restore that sense of choice, control, and autonomy is extremely important for trauma survivors. And one of the ways we can do that is to be aware of power dynamics and hierarchies and begin to work collaboratively. And the fourth pillar of TIP is strengths based and skill building. So, as I mentioned before, TIP is less about singling out people for special treatment, which can make people feel othered, but rather it's about substituting the question, what's wrong with you, and changing that to what happened to you. And so it's really about understanding and building on people's natural resilience and humanity and realizing that to get where they are in life, they have had to overcome a lot and show some kind of personal strength and resilience. And we want to tap into that as part of TIP. So, why is TIP or trauma informed practice relevant to a strategy for patient oriented research? Well, as I have discovered through my research over the last many years, trauma and health are very intimately interconnected. And there's at least three ways this can show up. So, the first one is medical PTSD. So, many people I speak with, including other trauma therapists, are not aware of how PTSD following a medical event is a unique form of PTSD or post traumatic stress disorder. And in fact, it might be even more prevalent than other forms of PTSD, but it seems to be less well understood. You can imagine that when people are in a healthcare environment, and especially if it's been a life threatening medical event, there's an appropriate focus on the person's survival and the person's physical well being and safety. But what gets missed in that often is that that can cause shock and trauma in terms of mental health effects. And so you see this in certain conditions such as stroke, acute cardiac events, cancer, brain injury, and also people who have had stays in the intensive care unit have elevated risk for medical PTSD. A second place of intersection of trauma and health is in terms of complex trauma. So, some of you watching this may be familiar with the Adverse Childhood Experiences study that was originally done by Vincent Felitti and his colleagues in the 1990s in California. And his findings have been built upon and replicated many times since. But that there is a relationship between adverse childhood experiences such as abuse and neglect and later health adversities that are found throughout the lifespan, not only mental health, but also physical health. So, some of those same conditions that I mentioned in terms of medical PTSD, there's actually elevated risk for those following adverse childhood experiences. When you couple that with being part of a group who is marginalized in society, maybe if you're from a racialized group, or you're a member of the LGBTQ community, or you're a refugee, or you're from a lower social class, you may have experienced systemic inequities, and that might mean it has been difficult to access culturally safe care. And that can become its own source of trauma. A third point of intersection is specifically complex relational trauma. And so this relates to one of the projects that we've recently completed in our research lab. But complex relational trauma is a specific form of complex trauma, and it pertains to adverse childhood experiences, is one of them, but any kind of close relationships that are characterized by abuse or neglect. So you can also see this in intimate partner violence in adulthood, and sometimes things like workplace bullying and harassment. And these abusive and neglectful relationships create injuries to our attachment system, where attachment means the normal, healthy, secure relationships and bonds that we form with other people. And sometimes these attachment injuries get reactivated in healthcare contexts. And I will often have this conversation with my clients, and sometimes they've been surprised to think about this. When you think about when you're physically unwell, by definition, you come into healthcare and you're having to put your physical personhood in the care of some powerful other people who have some degree of control over you. And that can easily bring up reminders of other times when your physical and perhaps mental and emotional well being was under the purview of some powerful other people, whether it be a parent or a caregiver who is abusive, or even a partner who, for example, has financial control over you in the case of intimate partner violence. I just want to include a couple quotes here from one of the recent studies that we did that really capture this connection between trauma and health. With trauma disorders coming from a childhood where I was taught that I was less than everybody else, not being listened to reinforces the I'm the dummy here and you're the smart one, and I need to shut up and let you tell me what to do. That's where it re traumatizes. Actually, trauma informed care is super simple. It just means that you're not making things worse while you're interacting with that client. So now we've discussed what is trauma informed practice, what is patient oriented research, how do we bring those two things together so that if you're a researcher who conducts patient oriented research, how can you use this knowledge and leverage it in a way that can create a more supportive engagement experience for your patient partners? Because if it's not clear by now, what's implied in what I've said so far is that if you work with patient partners, you can almost guarantee that at least some of them will have experienced trauma or be currently dealing with trauma. So, this was a study that we recently completed and published our findings. And I'm using this as a general template for some of the ways that you could think about approaching patient engagement from a trauma informed lens. And so this was something called a Delphi study, which is a consensus study where usually a group of experts come together to reach a consensus on some topic in healthcare. So you may be familiar with Delphi studies, maybe you've conducted them yourself. But one of the things that was unique, I believe, about the Delphi study that we did was that we actually had patient partners as part of our expert team, patients being the expert on their own lived experience. And so, even though the purpose of the project was to develop trauma informed practice guidelines, we really tried to walk the talk in every aspect of how we actually conducted the study and engaged with our patient partners. And based on the really positive feedback that we got, this is kind of a model that we have used in all our subsequent studies and has been really successful. So, what are some ways that we can walk the talk of TIP in terms of how we engage with and even how we recruit our patient partners? So, this is something that's important to be thinking about through the life cycle of your entire project, even when you're designing the project and before you've even met a single patient partner. So, thinking about that disability advocacy mantra, nothing about us without us, thinking more carefully about who is the us that we're platforming here, whose voices are we actually amplifying? Now, it may be the case that people who want to engage in patient oriented research have a certain amount of privilege that allows them to do something like be part of a research study in this capacity. So they might have economic privilege, they might be health literate, they might have read scientific studies themselves, they might be from a professional background. So we have to be thinking about, are those people actually representative of the broader community of patients that are relevant to our healthcare study? And so there's been a term talked about and used certainly in psychology for the last several years called weird samples. And weird is an acronym that stands for Western, educated, industrialized, rich, and democratic. And discussion of weird samples was really brought forward to critique the studies that we're doing in psychology. How representative are they of people from a multiplicity of diverse backgrounds? And so there's really been concerted efforts, at least in psychology, to have more diversity in the people that we recruit for our studies and also in the ways we ask questions and the types of questions that we ask. So, one straightforward way that you can apply this information to thinking about even the recruitment of your patient partners is to use an intersectional lens. And we often refer to Pamela Hayes' addressing model, and addressing is an acronym. So, to be thinking about some of these factors when you think about how you want to recruit patient partners to be part of your team. And I guess what's implied in this is it's often really helpful to have more than one patient partner on a study so that you can have more of that diversity. So, addressing stands for age, developmental disability, disability that's acquired, religion and spirituality, ethnicity and race, socioeconomic status, sexuality, indigeneity, national origin, and gender. And as is discussed in the article that's linked here by Shimon and colleagues, it's really thinking about epistemic justice in knowledge production. So, what that means is, are we platforming a multiplicity of voices when we decide how knowledge gets produced, what knowledge gets produced, and how it's actually shared with the public? And are we making sure to bring in as diverse a group of voices as we possibly can? So, we have some recommendations you can think about in terms of how you go about recruiting patient partners and what type of patient partners you might want to recruit. So, the first recommendation is consider multiple avenues for recruitment. So, these days, especially since COVID, online recruitment is very popular. But bear in mind that not everyone has access to a computer or phone. So, for example, here in British Columbia, we have a healthcare research portal called Reach BC that often advertises opportunities for patient partners, but only a certain amount of people might know that that platform exists and also have access to a computer or a phone to be able to look up the website. So, you can certainly use these routes, but again, you might want to think about diversifying how you reach out to the public. And this is certainly true if you're working with marginalized or highly stigmatized communities. You might have more support if you actually make contact with community champions who can facilitate recruitment for you, and actually taking the time to build those relationships in community prior to the initiation of the research. So, for example, in our study where we worked with people who had suffered anoxic brain injury following non fatal opioid overdose, this is a community of people who are often very marginalized in society. Often they have unstable housing, they might not be in steady employment, they may not have access to a phone, certainly not a computer. So, we work closely with our community partners and built a relationship so that they could facilitate recruitment for appropriate patient partners. As someone who has sat on the Human Research Ethics Board at my university for several years now, I also know this is really important. For example, if you want to work with any kind of Indigenous community members, that it's really important to build those trusting relationships even before you submit your ethics protocol. Because again, many people from an Indigenous background will have suffered a variety of different traumas. So, once again, building that safety and trust and collaborative relationship is absolutely essential. The second recommendation is give some thought ahead of time to the composition of your ideal patient partner team such that you could maximize diversity. And think specifically about barriers to and facilitators of participation. So, thinking about what is the time commitment required to be a patient partner in your study. So, some people are going to have more or less time available depending on their life situation. So, for example, retirees might have a lot more time available compared to busy parents of small children. Similarly, people who are of lower socioeconomic status and might be working in minimum wage or low wage employment might not be able to afford to take time off from work, but their voices are equally important. So that means thinking about what you can actually offer in terms of monetary compensation for participation. And a third consideration is access to a device required to participate? So, again, if you're doing most of your work online, this means a person has to have access to a phone, a computer, and a reliable internet connection. And think about who that will include versus exclude. So, for example, for myself working with people with chronic health adversities, sometimes doing things online is actually quite good because it means someone doesn't have to travel to a different place, which can be challenging if you have health conditions. However, if you're rural and remote and in an area that doesn't have good internet, or you're in an economic situation where you don't have access to a phone or a computer, this could be problematic. So again, I reference the study that we did with people who'd suffered non-fatal opioid overdose. We made arrangements for our community partners to have iPads so that if need be, our patient partners could come to the community centre and actually log on to the iPad with the community partners' support so that they could be part of our team. And the last part of recommendation 2 is thinking about how you will compensate your patient partners. So some people might be fine with vouchers. Other people might require cash, again, because they don't have the ability to get reimbursement from vouchers. Some people are fine to be paid at the conclusion of a study, and other people would prefer to be paid after each individual engagement with your team. So this is where community partners can be helpful in trying to determine what's going to be the best way to compensate your patient partners. A third set of recommendations is thinking about what is required for patient partners to give full informed consent for participation. So one of the approaches that we have used that's been quite successful is to offer a no commitment public talk with Q&A. So whatever the topic of our study is, we give a broad public talk on that topic, and then people from any background are welcome to attend. If they're interested in being a patient partner, then there's opportunities for dialogue. But if they decide they're not interested, at least they've learned something new about that topic. It's also helpful to provide some kind of written information on study participation because people might not remember everything that was covered in a public talk. And making sure to clarify the difference between being a study participant and a patient partner, because that might not always be understood by people who apply. It's also really important to encourage self-reflection about timing and self-care needs. So some people could be wonderful patient partners, but it's just not the right time for them because there's a lot of busyness or other responsibilities in their life at that time. So letting people know that it's okay to step back at the current time and they may want to participate at some other time. And of course, it's really useful to partner with your local support unit, particularly if you're in Canada and your province has a support unit, because they're a wonderful source of support, unsurprisingly, for onboarding your patient partners and getting them up to speed once they have been recruited. So this was a booklet that some of my students put together, Your Voice in Research, a guide for patient partners. And we can link this under the description box of this presentation. But this was really a written guide just to let our patient partners know what is research, what does it mean to be a patient partner, and what are some of the things that you can expect, and what could you possibly get out of this experience. So this is really giving a lot of thoughtful information so people can take the time to really consider, is this the right opportunity for me at this time? And again, giving information is part of the way we support informed consent. So now you have your team of patient partners and you're about to begin your project together. So let's return to those 4 pillars of TIP. And then think about how they apply to engaging with your patient partners in a trauma-informed way. So if you're new to the intersection of trauma and health or trauma-informed practice, then a good place to start is always your own background knowledge. So our lab has created many different resources that talk about the intersection of trauma and health, and we'll make sure that there are some links to those resources in the description box of this video. They're of course not completely exhaustive, but they're at least a good start for you to get up to speed on the connection between trauma and health, so you can feel more confident with your patient partners. Here I show you an excerpt from a workbook that we created for that Delphi study that I mentioned earlier. And so when we began our work together, we had our initial meet and greet, and then everyone on the team, regardless of their background, was given the same workbook. And my students put together this workbook. So it included an introductory section, some self regulation techniques, which I'll talk about in a moment, some topics of interest. So this was talking about the intersection of trauma and health and brain injury, and also what is a Delphi study so that everybody knew what we were going to be doing, and then a conclusion. And the reason for us all to have the same workbook is so that we were all on the same page and we're using the same language to talk about the same things. So as a way of dismantling that hierarchy, so we're all working together as a team and patient partners can feel like equal participants on that team. So, tip pillar 2, safety and trustworthiness. One of the most important things to know about how to cultivate safety and trust is container principle. And as my Indigenous clients would often say, it's about how to start and end in a good way. For most people who are dealing with trauma, and actually many people who are dealing with chronic health issues, it can feel like living in chaos. There's often a lot of instability and uncertainty, and a sense that one more thing could be the thing that knocks me over completely. So it's really essential that being part of a research study doesn't further contribute to that chaos. Many of us who work in academia are used to being in a very high stress, fast paced environment with lots of deadlines and working very late hours and so on. So there's a certain amount of chaos that we probably tolerate and adapt to as researchers and trainees. But that is not going to be conducive to a trauma informed way of working with your patient partners. So it's important to really think about how you can step out of that mode of being, at least in terms of working with your patient partners. And being able to establish a really solid container can create a sense of ease and safety, and everyone can feel held together in a shared project. And I'll talk more about how we actually practically create that container. But some things to think about. Cultivating a sense of trust takes time. People may be motivated to be patient partners actually because they've experienced wrongdoing in the healthcare system and this is their way to make right. So we want to be respectful of that and acknowledging that and realize that trust takes time. And if I have learned anything over my years of being a trauma therapist, it's so helpful to just simply show up authentically as a human, to be able to take off the mantle of a academic and a researcher and just show up as your authentic human self and value the relationship, not just as a means to an end, but because it's actually valuable to make an authentic human connection with another person. Say what you mean and mean what you say. That is, follow through on commitments and be clear and transparent in your communication, including expectations for the project and opportunities to consent. Now, patient-oriented research doesn't always involve having a consent form for your patient partners, but this is generally what we have ended up doing in consultation with our own human research ethics board, is to have some form of consent form for patient partners so that everything can be spelled out, they know what to expect. And where possible, we'll also put a timeline for the project and a timeline for their expected engagement in that written consent form so that they can have that as a reference point. And that actually provides a certain amount of container. So we can talk about container as the overall structure to the project, but there's also container in terms of people's emotional responses or reactions to the work. Again, acknowledging the fact that many people who have been involved in healthcare in a serious way have suffered trauma. And so it's understandable that even with the desire and the ability to be a good patient partner, it may stir up strong feelings in some people. And so part of container is just to normalize that and just acknowledge that emotions might get activated. And it's just a reminder with compassion for patient partners and really everybody on the team to engage in good self care. And I'll say more about that in the strengths and skills section. Endings can be really difficult for people who have suffered trauma. And so the starting in a good way is important, but also ending in a good way. And so you may even ask people at the beginning or towards the end, what would it be like to end in a good way in terms of their participation? Is there anything that would be meaningful in terms of closure? Sometimes it's as simple as just a final meeting, but if you're working with people from different cultural groups, this would be a good time to see if there's any cultural protocol about how to end in a good way, and that's where you really bring in that cultural safety. We'll link some additional videos here that we've created as part of our research that talk more about container principle as well as how to cultivate a sense of safety and what's referred to as neuroception, which is a felt sense of safety. Tip pillar 3, choice, collaboration, and connection. So this is where it's important to clarify expectations early on about what collaboration actually means. So you may have different expectations of your patient partners depending on the nature of the study, or this might actually vary across the different studies that you do. And we've certainly experienced this in our projects. Some of our studies, patient partners were mainly involved right at the beginning, and then the research team kind of took it from there all the way up to the complex relational trauma healthcare toolkit, where our patient partner was actually the project co-lead for the entire project. So they were highly involved all throughout the process. I would just refer you to the IAP2 spectrum of public participation. This can be helpful to think about again in the planning stages of your research and then be able to communicate that clearly to your patient partners. And you could share this infographic with them and then talk about, from a practical point of view, how this translates to the work they're actually going to be doing in your study. So we often find that we are working with our patient partners at the level of collaborate, but it may be different for you depending on the nature of your studies. And so just thinking a bit more concretely about how to cultivate team building when you're working with patient partners. So even though they've signed up to be a patient partner, sometimes there might be some nervousness or anxiety about being good enough, sometimes that imposter syndrome, sitting in a room of researchers, healthcare professionals. So we want to make sure everybody feels comfortable and on a level playing field. And one of the strategies that we have found really helpful in this regard is to have an initial session where the only agenda item is simply to get to know each other as people, of course, in a professionally appropriate way. Um, Sometimes we've used, like we call it the squirrel infographic, where you can easily find this on Google, where there's 9 different squirrels that all have different expressions, and ask people to say what's their squirrel for today, and then ask them to share a little bit about why they were inspired to be part of this project. And is there something good they want to share about themselves? So it sounds basic, but it's just a way to signal to patient partners that you care about them as people and you value being able to connect with them just on a human level. And that can already begin to build trust and is a nice way to open your container together. It's also good, as I mentioned before, to establish a shared language for the work. And this is what I refer to as democratizing knowledge. So, that workbook that I mentioned that we created, to make sure that we're all using the same words and the same definitions so that people don't feel othered if they feel like they don't know what a certain word means. Because in healthcare, we're all used to using certain jargon, abbreviations, technical terms, and that can feel very othering to patient partners. So we want to make sure that everybody's using the same language and feels comfortable to participate equally. In group meetings, allowing people to decline to respond, or they can have the option to respond privately. Sometimes we'll have patient partners, they don't want to speak in group, but they'll send a private DM or an email. Bear in mind that people with cognitive disabilities might need extra time to process information. So, if you have a group meeting and important information is shared, make sure that you do some kind of written follow up. Could be a Word document, could be PowerPoint slides. We've created videos as well. So, making sure that people have multiple ways to access information and also some kind of tangible record that doesn't require them to remember everything that's talked about in a meeting. And with that, each time you're asking a patient partner to complete a task for your project, think about what options you're giving them for their preferred mode of participation. Again, depending on the population, if you have people with severe fatigue, or for example, if we've worked with people with stroke, they might have language difficulties or memory difficulties, or we had people with anoxic brain injury, so they might have had memory problems. So, thinking about giving people different ways to participate so that everybody isn't forced into the same box. So, just show you another snapshot from this workbook that we created. And we wanted to set the tone right from the beginning of the workbook to let everybody know, including the patient partners, that people were not expected to know everything ahead of time. And in fact, that was the reason that we were providing this workbook to actually give people information on the topics that we were going to focus on in the study. We actually did a self assessment at the beginning and the end of the workbook so that all of the participants in our research team could do a self assessment and see how much information they knew about the topic coming into it. And they didn't have to share the results with anyone, it was just for them themselves to have a sense of how much they knew. And then they could see by the end of the project how much they had actually learned by participating. And then tip pillar 4, strengths based and skill building. It can be helpful to think about being a patient partner as an aspect of post traumatic growth. So, as I mentioned, healthcare and trauma are intimately interconnected. But usually, if somebody's motivated to be a patient partner, it means they've reached a certain state of well being or recovery that they feel that they want to give back. And you'll hear this a lot in trauma survivors, certainly in the people I've worked with various types of brain injuries. They're often really keen to want to give back to their community. And so, just to affirm that as an aspect of strength and resilience. And patient partners really appreciate it when you emphasize to them that they're leveraging their knowledge, their own lived experience, as a way to give back to their community and pay it forward. And that often feels really meaningful to them. It's helpful to acknowledge the emotional labor that may be involved in the work. So, again, by engaging as a patient partner, you're being asked to reflect on your own experience, and sometimes that experience is not positive. It may include instances of trauma that have actually happened within healthcare. So, we're asking people to engage in something that might stir up difficult emotions and that they're going to have to work to manage those emotions. So, there is that emotional labor involved. And that's why we want to create structures of support so that people can engage in effective self care along the way. So, some examples are again this container principle. Now, I talked about it as an organizing structure for the project, but there's actually a technique that you can teach people to use in terms of container. And I'll link that video in the description box, along with a couple other videos that talk about tools for self care, such as grounding and then something called the butterfly hug. And if you're not a mental health provider and you feel like this is out of your scope to be teaching these practices, you can simply refer people to the videos that I link. We'd be happy for you to use those. And just reminding patient partners and the team to orient to positive experiences outside of the work. So if they get emotionally overwhelmed, just remind them to be able to put the work aside in terms of container, and then to engage in the other things in their life that actually bring them joy and well being. So here's another excerpt from the workbook that we created that talked explicitly about the fact that they may be required to engage in some self-regulation strategies if difficult emotions come up during the project. And this proved to be very helpful on a number of occasions when our participants felt activated by some of the material. So rather than seeing it as a problem to be managed, it's more helpful to just acknowledge upfront and normalize. This might be difficult. Some difficult emotions come up, but that's not a problem at all. It's just an invitation for self-care, and that people can take breaks when they need to. And then we gave some information about grounding strategies. So to bring all of this information together, just as a reminder, TIP, trauma-informed practice, is a systems level practice. It applies in healthcare, in the topics we decide to research, but it also applies to the members of our team and how we approach working together in a good way. And in conducting patient-oriented research, it's important that we actually walk the talk and bring our patient partners alongside us in the work we're doing. So in conclusion, patient partners can be valuable members of our research teams to create results that are applied and ecologically valid for healthcare. People with significant health conditions may be carrying the experience of trauma, including trauma specific to healthcare experiences. And as much as trauma-informed practice is a valuable approach to healthcare, it can also be a useful model to create a welcoming, inclusive environment for patient partners. Positive experiences can be reparative for relationship ruptures that have been sustained within healthcare. What that means is your patient partners may have had difficult or even, frankly, traumatic experiences within the healthcare system, and being a patient partner can be their opportunity to have a do-over, to be able to pay it forward, but also to have a good experience with you that might cause them to reappraise their views on healthcare. I just want to thank our various funders, supporters, and collaborators of all our work over the years. But again, a special thanks to the BC Support Unit, who has really walked with us every step of the way in terms of our work with patient partners. Thanks to the amazing, inspiring, and hardworking patient partners our team has had the pleasure to collaborate with, as well as my own clients who really inspired me to pursue this work. We're all just walking each other home. If you have more questions on SPORE, I recommend that you go to CIHR's hub for the strategy for patient-oriented research that's linked here, or contact your local support unit if you're in Canada. For further resources on trauma-informed practice in healthcare, we're currently in the process of updating our lab's websites, but you can follow the QR code here on the screen for contacts. And if you want to specifically learn about trauma-informed practice when it comes to complex PTSD and complex relational trauma, there's a lot of good information in the project that we just completed, this healthcare toolkit that comes from survivors' own voices. And for that, you can go to www.outofthestorm.website. Thank you for your attention.